Okay, in this video, we're going to discuss the Corynebacterium. The most important of the organisms that we're going to discuss that's a Corynebacterium is Diphtheria, which is literally the causative agent of diphtheria, which many of you have probably heard of before, or although it is very unlikely you've ever seen it. We will briefly discuss the organism Corynebacterium jacam very briefly, as it is not a very common pathogen. So, as I've mentioned before, I study pretty well in tables. And this is one of the tables that I made for the old curriculum. And it's one that I'll release to you in blank form fairly soon as we cross off some more of the organisms on this list. And as you can see, just looking at it, you've already learned a lot of them. You've learned the bacilli, you've learned the Clostridia. Today we're going to cover the Corynebacterium, and you've learned Listeria. Nocardia, actinomyces, and Mycobacterium you'll learn at different points in the curriculum, but you can see that in this table we're talking about basic characteristics of the organism. And so for Corynebacterium, this is an aerobic organism. It's not a spore former, because remember, we only have two that are spore formers that we actually kind of pay attention to, and that's the Bacillus and Clostridia genuses. It doesn't go intracellular, not like Listeria or Legionella, which can go intracellular. And acid fast actually has to do with the presence of mycolic acids in the organism's cell wall. And Mycobacterium, which is the genus that Mycobacterium tuberculosis belongs to, certainly follows into that category. And it's not a filamentous rod, which is what we see with Nocardia and actinomyces. So you're learning a couple details of these in advance. The reason I went through it is just to kind of give an introduction to what you already know and what you will learn. But for the purposes of this video, really the only thing you need to take away from this slide is that the Corynebacterium are aerobic organisms. All right, so let's talk more specifically about the Corynebacterium. The Corynebacterium are a large heterogeneous collection of more than 100 species of organisms. As I mentioned, we're only going to cover two, Diphtheria and jacam. It's a ubiquitous organism. You can find it almost anywhere. It's found in plants, in animals, and they're kind of normal flora of the skin and the upper respiratory tract, the GI tract, and the urogenital tract. So we find this, in us. Almost all of the species of Corynebacterium can function, though, as a pathogen. So even though we see them everywhere, they can be pathogenic, but most of the time they're not. Relatively few of these are actually associated with human disease, and really the only one that is associated with significant human disease is diphtheria. It was once a really major cause of illness and death, especially among children. This was a rather severe disease for children, and this was prior to 1920. In 1920, the diphtheria vaccine became really prevalent, and it's a very effective vaccine. So now we don't really see it. Between 2004 and 2015, we've only seen 2 cases in the US. So why am I wasting your time talking about a disease that we never see because we have a great vaccine? Vaccines are not as reliable as they once were, not because they're not functioning, but because people aren't getting them. And anytime we see a decrease in herd immunity, we start to worry about how we might see some of these diseases that we never saw before. The vaccine for diphtheria is actually the DTaP or the Tdap, depending on your age. And so we've seen an increase in pertussis, which is the P in these DTaP and Tdaps. And since the D in these is diphtheria, when we see an increase in one, we start to worry about increases in the other ones. So what does it look like? Well, after an overnight incubation, if you're looking at this diagnostically, you'll see large colonies on blood agar, but a more selective and differential media is actually recommended. So in that case, you're going to use something like Tinsdale or Leffler's plus potassium tellurite media. Why? Well, because when we're culturing this, we're actually going to culture it most often from the upper respiratory tract. Your mouth is a cesspool of bacteria. There are so many bacteria in there, and some of them cause diseases sometimes when they overgrow. And Corynebacterium diphtheriae might get outgrown faster by something else that's more prevalent in your mouth. So using this selective media makes it more likely that you'll recognize this pathogen from specimens where other organisms are present. So the agar is enriched with tellurite, which basically inhibits the growth of most of the other microorganisms that we might see in the upper respiratory tract, including gram-negative rods. It inhibits gram-negative rods really well. And what the tellurite does is it makes it so that it grows this like black-gray color on the blood agar. So it's kind of pretty telling. Leffler's serum is a little bit slow, another way that you can isolate this organism. It allows for rapid growth, 6 to 8 hours growth of these small white opaque discs. So that's one way you could look for it. Although that's not typically how we diagnose it, that's how you can look for it in the lab. Just some other features about it. It's primarily an aerobic organism, but it can be a facultative anaerobe. So if it goes somewhere in your body, like the gastrointestinal tract, where oxygen isn't maybe easily available, it can function as an anaerobe. It's a non-motile organism, and that's important. Wherever it sets up infection, the bacteria itself is going to stay there. It's a localized infection, but it produces a toxin, this diphtheria toxin, and the toxin is what we call metastatic. The toxin is what's going to move to other distal sites in the body. And even though you've got a throat infection, you could potentially have cardiac or neurologic symptoms. And it's not because the bacteria has eaten its way through, like we saw in staph and strep. It's because the toxin is traveling to other locations. So it really has only 2 methods of causing disease. It's a quickly growing and highly inflammatory pathogen. So that means you can get really sudden symptoms. And these sudden symptoms are actually typically due to an exudate that forms, which we'll talk about in a second. The second reason is, you guessed it, another toxin. So you got to know your toxin. I'm going to actually give you a mnemonic device to remember this one that both Sketchy and Step 1 came up with, which I think is helpful. So as I mentioned before, this is a non-invasive organism, and that's true, but the toxin will go other places and cause damage. The toxin is not unlike anthrax, where it's an A and B subunit toxin. We see that a lot with toxins. The diphtheria toxin is an exotoxin that basically got introduced into strains of C. diphtheria by a lysogenic bacteriophage. So this is one of the few times where I think that reading that I gave you in Jamie Lopez, that was like the basic bacteriology reading. This is one of those buzzwords from it, bacteriophage. And particularly, it's called a betaphage, which I don't think I included in your reading, but basically that's just a type of phage. So you've got your A or active subunit. For A, it causes ADP ribosylation. And specifically, it causes ADP ribosylation of elongation factor 2. So what the heck does that mean? That's a really fancy way of saying that it basically stops, it's a terrible stop sign, but it stops protein synthesis. It's stopping your ribosomes. What do ribosomes do? They make proteins. If you can't make proteins, you die. So it's a really fancy way of basically saying it inhibits protein synthesis or inhibits ribosome function. The B subunit, as we found in other AB toxins, it allows for binding. So in this case, it actually binds to heparin binding epidermal growth factor. And this is a really common thing, this epidermal growth factor. As you can imagine, you've got epidermis or cells that are similar to epidermis throughout your body. So this is a really common thing found throughout the body, certainly on the epithelial cells of our throats, but also in our hearts, our brains, and our kidneys. So it allows the toxin to have effects in all of these distal sites if it can get to them. So that's kind of the 2 ways it causes disease. So what does disease actually look like? Okay, so the most common disease associated with C. diphtheria is respiratory diphtheria, this respiratory disease. The incubation period for this organism is roughly 2 to 4 days. And basically, it can involve any mucosal membrane site in your entire body. But really, we're most often talking about the nasopharynx. Transmission is made by aerosol, so we breathe it in. And the organism is going to colonize the epithelial cells in the oropharynx, and it's going to cause this localized damage, basically as a result of the diphtheria toxin. And the onset is kind of non-specific. You get kind of your typical symptoms of illness. You get, malaise, certainly a sore throat because we're getting this damage in our oropharynx or nasopharynx, and kind of fatigue, things like that. But the most important thing is actually this quickly spreading hard exudate. It looks almost like somebody who was chewing gum, like shoved a piece of gum up to the roof of their mouth with their tongue. Like it looks really thick, right? This exudate is more than like your classic exudate that you see with like strep or staph or some of the viral infections, because it's more than just an exudate. It's actually a pseudomembrane. The pseudomembrane is really firmly adhered to the underlying tissue, and it's difficult to dislodge. And if you note right by the black arrow, I was just hoping that I didn't like cover it with my green pen, but I'm circling it right here, and I'm kind of putting a little more arrow there. There's that little bit of redness there. If you try to dislodge the pseudomembrane, often you might get some bleeding. And that bleeding is from where they tried to remove the exudate. So if you have like a typical pyogenic pharyngitis, it doesn't move that fast. And it certainly won't be this firm, hard exudate. So what do I mean about how fast? We're talking a matter of hours. A typical, pharyngeal infection doesn't move this fast. So kind of the classic story that Dr. Goodman used to tell when he used to give this lecture is that you have an M3 who's on the floors who looks in the patient's mouth and sees a little bit of exudate. And they write on the chart, subtle exudate pharyngitis. And about an hour or so later, their resident comes through, and they see what they consider to be definite exudate and pharyngitis. And they're like, are you crazy? That's definite exudate. And you're like, oh, okay, I must have, misclassified it. No big deal. An hour later, the attending comes by and he sees what's known as bridging. He sees this, or she sees this thick, firm exudate making its way basically across the oropharynx. And basically looks at you and says, what do you mean you said subtle pharyngitis? That means in like a matter of hours, we went from a few specks to now this hard piece of gum making its way across the mouth. So that's how quickly this can move. And bridging is another classic symptom. Now, if you think about the other ones, like streptococcus pharyngitis, you see like those little flecks, not this tissue glob, and they weren't always all connected. So it's very different. So why is this such an important thing to keep in mind? Remember, this was a disease of children, and especially very young children. So in very young children, their noses are very small, very flattened. They sometimes don't breathe very well out of them. Their throats are small, and this exudate is going so quickly that if it bridges it across, you can get asphyxiation just from the exudate. And that was actually a way that some children died of this. They might, choke on it. The other thing that we would occasionally see with this is this. It's called bull's neck lymphadenopathy. C. diphtheria is an incredibly inflammatory disease, and it basically creates this massive amount of inflammation in the lymph nodes, and that causes all this swelling that you're seeing here. Okay, so the other thing is, as I mentioned before, this isn't an invasive organism. So when we are talking about metastatic C. diphtheria, again, we're talking about the activity of the toxin. So in this case, C. diphtheria is going to stay in its primary site of infection, but it's going to allow its exotoxin to go out and do its dirty work for it. So when we have this exotoxin go out into the world, where it's going to cause damage are places where the exotoxin can bind to that epidermal growth factor. So we see that it binds in the heart. You get severe inflammation of the heart, which basically leads to myocarditis. This occurs approximately 1 to 2 weeks after the pharyngeal symptoms resolve. So you get sick with respiratory diphtheria, you get better 1 to 2 weeks later, myocarditis. Neurotoxicity or demyelination, basically this leads to your nerves have myelin, which wraps around them and kind of insulates the electric impulses going down your nerves. That's kind of that's basic neurology, how nerves get signals throughout the body. Think of it like cables or wires. If you cut the rubber off of them, the signal is no longer insulated, and then the signal is easily lost or dispersed or doesn't fire right. So if you get demyelination, it's kind of similar to the symptoms that we see with MS. So in this case, we'll see demyelination of the nerves near the posterior pharynx. You can also get local paralysis, which can lead to some oculomotor or ciliary paralysis. And occasionally you'll even see as much as peripheral neuritis. And then the last thing is acute tubular necrosis, which basically is just kidney damage. So that's kind of the main scope of this. So how do we treat it? Treatment is actually not so bad. Since most of the damage is due to the toxin, you use an antitoxin, diphtheria antitoxin. If you have a patient that you think has diphtheria, we actually have basically passive immunity, which are basically just antibodies that are specific for the diphtheria toxin. And they'll neutralize it, and then it can't get into your cells and inhibit the function of ribosomes. So damage gone. And then to get rid of the actual antibiotic is penicillin and erythromycin if you actually got infected with this. But I'll never ask you like that level of detail. I'm not going to ask you which antibiotic you would use to treat C. diphtheria because you're likely never to see it. But the antitoxin is a good thing to keep in mind. And thankfully, people are mostly vaccinated, and it is a good vaccine. The other thing with this one and why we really want people to get vaccinated is that we're the only host for this. So if we could eradicate it from us, we could eradicate it from the world. It's not like there are spores in the soil waiting for us. We are the main host for C. diphtheria. Even though the Corynebacterium are ubiquitous, C. diphtheria really just likes us. Okay, I talked about the culture of C. diphtheria earlier, but that's not technically how we often diagnose it. So let's kind of go through how we diagnose and treat it. If you suspect C. diphtheria, you're going to go ahead and treat before you get a laboratory diagnosis. You're going to do empiric treatment with this one because frankly, the lab is not going to get back to you on it for at least a week. We just don't see it enough. It requires special agar. It's a whole thing. So let's think of this. The majority of the population is vaccinated for C. diff, and humans are the only reservoir for C. diff. So theoretically, if we wipe it out, we could. However, worldwide, we still see several thousands of cases of C. diphtheria throughout the world. Not in the US, but everywhere else. And then now for a variety of reasons, people are avoiding vaccines. So you could potentially see it. So the first thing you would do is ask your patient, have you been vaccinated? Now, if they have, but the symptomology is really seeming like it's diphtheria, it still might be. It could have been a vaccine failure. Not everybody responds the same way. So what you could do is a blood draw, and you could look for anti-diphtheria antibodies, basically antibodies to the toxin, because that's what we're looking for. But that's going to take time. And it won't help to look for bacteremia in the patient because remember, this is a non-invasive organism. So you've got a couple options. You can take a swab and start growing it out. But what you're more likely to do is send a sample for this. This is called an ELEC test. This is an in vitro immunoprecipitation or immunodiffusion test to determine if the organism has the diphtheria exotoxin, and if it does, if the exotoxin is active. So what you do is you take some filter paper, that's this thing in the middle here, this big wide paper looking thing, and this filter paper contains diphtheria antitoxin. And you place it in the center of the agar plate. Then you streak the plate with a known toxigenic diphtheria strain, like this one up here. This is your positive control. We know that this strain of diphtheria has the exotoxin. Then on the other side, you streak the plate with a known diphtheria strain that does not have the toxin. That's your negative control. Then you streak the patient, you guessed it, in the middle. So when you streak the plate, if it's a known toxin, you're going to get these lines at 45 degree angles. And that's basically the toxin being pushed out. All right. And you don't see them down here. If your patient's strain has the exotoxin, once again, you'll see these fine precipitation lines of C. diff toxin at 45 degree angles to the antitoxin strip. So that's one way. Alternatively, you could technically take your sample and perform PCR for the exotoxin gene, but that's really not often done. It's very uncommon. And this is one of those bugs that if you find it for some reason, you're going to be notifying the CDC. They definitely want to know that. Okay, so I already talked about treatment a little bit. The vaccine is very effective. Everybody should get it. Make sure you're getting your boosters. Diphtheria antitoxin neutralizes the exotoxin if there's going to be an exposure. So when would you do that? Kid has diphtheria, you might give mom and dad antitoxin just to protect them. It's kind of a booster to help them at close contacts, right? And then you might also treat with antibiotic therapy, and you're going to want to isolate the patient a bit to make sure that they aren't spreading it. And that's it. Okay, so that was a whole lot of information. So when we're talking about Corynebacterium diphtheriae, what should you remember? Just remember your ABCs for the most part. The toxin, the A portion, does the ADP ribosylation of EF2. It was encoded by a beta-phage bacteriophage, and the name of the organism is Corynebacterium diphtheria, and you can detect it using ELEX test or treat it with erythromycin. So choose your E there. It's a club-shaped, gram-positive organism. It arranges in clumps and chains, and it's a pretty relatively rare pathogen that we don't see all that often. So that's kind of the big deal. All right, so I told you we'd talk about Corynebacterium jkm, and this is pretty much all I'm going to say about it. The main characteristics are the same as C. diphtheria. It is also a club-shaped organism. It's gram-positive. It arranges in clumps and chains, and it's a fairly rare pathogen. We really only see this one, though, in cancer patients. It's actually a major cause of bacteremia in cancer patients, and it can also lead to endocarditis, wound infections, foreign body infections. That means catheters, shunts, prostheses. And the main thing that we think about with Corynebacterium jkm is its antibiotic resistance. And that's always kind of scary. Anytime that we are thinking of an organism because of its antibiotic resistance, we understand it as a growing problem. It's highly antibiotic resistant. Currently, it's really only susceptible to vancomycin, which is one of your more potent antibiotics. Dr. Bradrick actually refers to vancomycin as practically chemotherapy. So it's a pretty heavy hitter. But that's all I'm going to say about CJKM. It's not, a big pathogen. I won't test you on it, but just so that you're aware of it if you're dealing with, any sort of cancer or immunocompromised patient. That's all for Corynebacterium.